Welcome everybody. It's a great pleasure to be here today and to be able to share with you all of my experience in orthodontic surgery, complex case treatment. So today we are going to have the masterclass that we are preparing for you and try to explain all these 30 years of experience that I have. Welcome everybody. We have here people from different countries. Where are you from? Which country are the people that are here today? Hi, Fernando Sintra, Ana, Ronaka. Welcome everybody. It is very good, very nice to have you here today with me. And I would like to introduce myself for you. I'm Vanessa Castro. I'm from Brazil. And I'm an oral and maxillofacial surgeon. I did my graduation school in dental school, and I finished my graduation in 1994. And after this, I did a 4 years residency program at the Hospital of Craniofacial Anomalies in University of São Paulo. After this, I did a fellowship at Northwestern University in Chicago, and then at Baylor College of Dentistry in Dallas with Dr. Larry Wolford. I did post-graduation and master and PhD in the same field, and I love to speak and to share my experience from almost 30 years working with skeletal deformities and having more than 3,000 patients operated from craniofacial deformities and with orthodontic surgery. So it is wonderful to be here today with you. And today we are going to talk about the workflow to get the best result for orthodontic surgery. So how do I do? What do I need to know to get the best result in my orthodontic surgery? What is the secret to get the best results? What I have to do? Which kind of protocol I need to follow to have this kind of result in patients with skeletal deformities? That's what I will talk with you today. When we think about orthodontic surgery, we have 3 major objectives that we have to think about it. It is to give to the patient function, aesthetic, and stability. So I can tell that these 3 pillars are the most important thing and the objects that you have to keep in mind when we start to do the treatment of skeletal deformities. And the objectives of the treatment is to get stability, proportion, health, harmony, symmetry, and function. Everything should be at the same patient, and you need to give to your patient all these parts, all these components, objectives, to get the best result in your patient. So, if you think about craniofacial deformity, we have the genetic factors that are the most important one to define and to determine the kind of the deformity of the patient. And we have deformities in all the axes in the face. So I can have a very severe deformity in sagittal plane or in the vertical plane or median lateral plane. So we have asymmetry, we have class 3 occlusion, class 2 occlusion, we have very discrepancy in vertical way. And all these points, most of the time, they are connective and they are directly related with genetic factors. So the genetic factors, during the growth, we can treat this patient with some appliances that we have to control the growth of this patient. But in adult patients, we need to treat or with orthodontics treatment or with orthodontic surgery. So we have to understand all these points when you have a patient. Skeletal deformity, we think about to get the best occlusion for my patient and to have a face very balanced. I need to think about the airway and of course about the TMJ. Everybody asks me about the TMJ pathologies and the relation with the skeletal deformity. And I can tell you, we have to be careful and we have to take a look very carefully with the TMJ in this kind of patient, especially if the patient is hyperdivergent patient, because they usually don't have TMJ health. And you need to know if I'm gonna treat the TMJ exactly the same time as orthognathic surgery or not. If I'm going just to do orthognathic surgery and just to control and wait the adaptation and the remodeling of this TMJ. We are going to talk about many things, and I will come back here and talk a little bit more about TMJ pathologies, and we can talk later about this. Hello, Camille from France, and I have people from Turkey. It is welcome very much for everybody. Dr. Carlos from Mexico, saludos. And let's talk about the treatment goals of orthognathic surgery. So we have three major pillars about treatment goals in skeletal deformities. I can have occlusion, a good occlusion, the best occlusion, the ideal occlusion. I need a facial balance, and I need to get better improvement of the airway. I would like to ask you people to put your doubts in the chat below here. So during the lecture, I will stop a little bit and try to answer the questions that you have for me, okay? So talking and returning here for my treatment goals, we need to get these 3 points in the patient. A good or improvement of the airway, the best occlusion that I can get, and facial balance. I need to think about it every time. What I can tell for you, the diagnosis is the key for the planning. So it is very important to understand that I need to get the best and the correct diagnosis for my deformity. That's the point, that's the key for everything that we are going to suggest, everything that is going to guide you in the treatment of this patient. And we have limits, we have repercussions about changing faces. And it is very common today, especially in women, to have a lot of pathologies that are not only physical pathologies. I have psychological pathologies, psychological factors, and the people start to do so many procedures in the face and start to lose the limit of what is beauty and what is harmony. And many times the professional sets the limit. We have to set the limit for that kind of patient because we have another factors involved with skeletal deformities, and people want to do everything by surgery. And we need to understand and we need to try to see this, to have this point of view. Like the superstar Michael Jackson, that was a great guy, but look at his face. What he did in his face. He didn't have any kind of limit to change. And he tried to put in his face other kinds of pathologies that he had in his life. So many times we are the majors. We have to talk to our patients and ask for the patient to stop doing and asking for more and more. And we have to understand that it is not always that more is more. And we need to control this, the limit. Many times the professional has to give. And now we are going to talk about the sequence of actions and the thoughts to plan your surgical case. If you have a patient in your office and the patient get in your office, the first consultation, the first step that I have to care and I have to keep in my mind is to get a good documentation of the patient. So I need photos from my patient. I need to evaluate the occlusion that I have in the first consultation. I need to see the CT scan, the casts, and the cephalometric analysis. So all these points I use in my first consultation with my patient. So when the patient asks for a first consultation in my office, I already have all these, and I look at the patient from the first time, taking all this evaluation with the skeletal deformity. About the photos, we need all the surgeons, or orthodontists, they have like a photographic protocol. And what is important is to have the same kind of photograph protocol before and after the treatment, because you are going to compare. So you need to have the same room, the same position of the head, the lips relaxed, the patient with a smile very naturally, and the back of the picture should be the same color, or white or black. And it is very important to put the patient in the correctly head position before and after the surgery. And this is a very important point just to compare. I don't do any kind of facial analysis with photos, with images of the patient. It's trying to help me just in the diagnosis, but I like to see my patient and touch my patient with my hands so I can view all the posture of the patient, the cervical spine of the patient, and I change the head position of my patient and try to see the best position that I need to do the measurements of that face. And it is very important. Another thing that is important for the first consultation, in my opinion, is the tomography. So today, it's very common to have the tomography from the first consultation, and we can see the TMJs, we can see the bone discrepancy, we can see all kinds of asymmetries, and we try to understand the difference and the proportion from the teeth and the bone. And I always do the 3D study from the airway of this patient. So the software that we study in the first consultation, the skeletal problem of the patient, I always do the 3D analysis of the airway. I always take a look in the TMJ and the cortical bone and what is going on in the TMJ, and the asymmetries and all the discrepancies that I can get in that arches, upper and lower arch. In this first step, the documentation, I need a plaster or digital models. I like, personally, the physical models, the plaster models, because I can put in my hands and I can change the position of the upper and lower jaw, and I can put the correct position of the teeth. And I think it is very important during the first evaluation and seeing the bottom discrepancy and see the transverse problems and sagittal problems too. So digital models are good and you can see in the computer, but I like to see the physical models too. And the question is, can I treat this occlusion without surgery? When I have the occlusion in front of me, I cannot say exactly the definition of the treatment just looking at the occlusion. I need to see the occlusion, the face of the patient, and everything, the main complaint of this patient, and try to see the best treatment for that deformity. So many times the orthodontists, they just are looking for occlusion and try to see some kind of appliance and the solution for that problem just with orthodontist appliance. But we have to compound, we have to see the face of the patient, and we need airway and all other functions. So, hi, Dr. Kleber, Dr. Gustavo, how are you? Welcome. The second step of my protocol that I would like to share with you is about the diagnosis of the case. So this is the most important one. I need to define the problem that I'm in front of. And I need to keep in mind how is the best way to do my diagnosis of that case, of that deformity. What is the most important point in that phase that I need to treat? What is the most important complaint of that patient that I need to treat and take care of and care about it? And of course, when we are talking about skeletal deformities, when we are talking about orthogenetic surgery, the treatment is guided by the face because we are treating the face of this patient. We are going to relate with occlusion and airway, but the face is the guide of the diagnosis of that patient. And for a good facial analysis, I need a natural head position of my patient, always in centric relation, and with the lips in relaxed position. This time, I always do my facial analysis with the patient in front of me. And I correct the natural head position. I need to put the patient in the right position from my hands. So I will start to measure this face during all the consultation, of course. When we are talking about facial analysis, I have the face reading protocol. It is a mathematics calculation. Everything in the face, we have to calculate it. We have the proportion, that is the ideal proportion. We have the distance of the lips, interlabial distance, upper lip length, lower lip length. Everything in the face, we have the best, the ideal numbers. And it is mathematics. We have to respect the duration of that patient, and we have to respect the pattern of that face. But I can measure the discrepancy of the bone from the upper and lower jaw easily. And we have a sequence, a protocol, reading that face. This is another lecture that it is very long. We have many details. I did a video for you, and in this video, I can tell about the evolution of the orthogenetic surgery in our field. So in the past, we always use a lot of plaster modules, and we use it to do the articulator, to do the model surgery, because it is a school from many years ago. We traced the patient from our hands with the cephalometric tracing. But about the facial analysis, it is the same. We have all the measurements, we have all the face of the patient in front of us, and we just reproduce in the models what I'm seeing in the face. So here you can say, you can plan the best way to do the surgery. And the facial analysis, even today, with all the technology that we have, the computers that we have, the softwares that we have, there is no other way to see and to determine the movements that we have to do, that you have to do in your patient, just with the software and the computer. You need to read the face and see the numbers of that face. We have to evaluate the TMJ with MRIs, with CT, and try to fit everything in the same plan. Today we do a lot of things with softwares, and we have the predictability in the results of our planning. And we can see the changes in the pogonio, the maxilla, the AP point, the pogonio, and there is more predictability. I have more predictability in my plan, but what is the guide always is the face of the patient. But if you don't see, you cannot change. If you don't see the problem, if you don't see the major pathology that the patient has, you cannot change this. You need to understand. The first step of your protocol is the decision. When you have a patient in your office, you have to decide, this is a surgical case or non-surgical case, or it is a borderline case. Which kind of patient I'm in front of? How is the best treatment that I will suggest for this patient? A surgical or non-surgical? So the diagnosis of the deformity, we are going to evaluate the morphologies of the face. And we are going to see functional, aesthetic goals. We are going to compare what is the best for this patient, orthodontic surgery or compensate the case. Just orthodontics for that patient. We have to compare skeletal and malocclusion and with sleep apnea for the patient. And we have a lot of patients that are class 1 occlusion, but the bone, the upper and lower jaw, is totally out of the position. And the patient has bad health and a lot of problems in the airway. So we can suggest for the patient orthodontic surgery in patients even with class 1 occlusion. That's no problem. What is the criteria that I use to define if the case will be surgical or non-surgical case? So first of all, I will see the occlusion. And I will try to understand if the occlusion will be stable after the treatment. If I will do any kind of orthodontics for this patient, it will be stable after the treatment, or I need a surgery to help with the stability of that case. Does the patient want to change his appearance or not? The patient is worried about the face, or the patient just wants to get better occlusion? Does it have any function problems, TMD, apnea, any kind of problems with the breathing? And how is the patient smile? It is very important analysis, because if I have problems in a skeletal point of view, it's very hard to try to compensate this case with non-surgical treatment. Look at this occlusion. With surgery, this is a patient with a very huge open bite, and at the beginning of the treatment and then before the surgery. And here, the last picture is 4 years post-surgery. So with the orthodontic surgery, we have the occlusion more stable in long term, because I change the bone position and the healing of that bone, and I will treat just the muscles and the adaptation of the tongue, and it is better to control and to have stability in long term in very severe open bite with skeletal deformity and skeletal discrepancy, very huge skeletal deformity. And defining if a case will be surgical case or non-surgical case, the next step that I have to think about it is the definitions of orthodontics preparation. What I will do to prepare this patient for the surgery. I have to understand and I have to decide the type of the surgery that I will suggest for this patient. Extractions, if I will indicate extractions or not. Leveling, transverse problems, bolt-on discrepancy, and the discussion. Until now, if you have any doubt, you can put on the chat here, And at the end of the class, the lecture, I will try to answer all the doubts that you have. So put your question on the chat, and we are going to answer at the end, okay? So coming back to the fourth step, the step 4 is the ortho preparation for orthogenetic surgery. We need all the definitions before the treatment. It is not something that we are going to decide during the treatment. I need to understand everything that the patient needs at the beginning, at the first time, and to plan all the modifications that I will do on the teeth before the treatment. So the decisions for treatment plan. First of all, I will answer what is the type of the surgery that I will suggest for this patient. Is there a necessity for extractions? Which teeth should be extracted? This is a very important question. How should transversal problems be solved? And how should the occlusion curves be leveled? So all these questions should be answered at the beginning of the treatment. And this is something that the surgeon will decide with the orthodontist. It is very important to have this kind of decision together. Both professionals had to decide together. The surgeon will help the orthodontist to see something that he needs for the surgery, and the orthodontist will help the surgeon to understand what is the best way in orthodontics point of view to decide if it is better to do extraction or not, how we are going to solve that kind of movement. And if there is some bolt-on discrepancy. When we talk about type of surgery, what I'm talking about? I'm talking about monomaxillary or bimaxillary surgery, single or multiple osteotomy. And when we think about monomaxillary, I'm talking about to do surgery only in one bone. What it means for you? It means that I have a guide bone. I need one bone that is going to be my guide or maxilla or mandible, and the other bone that is the problem, the pathology bone, that I will do the surgery. And it is very important to see all these details. I need to look at the midline of the bone that it will be the guide one, the leveling, the symmetry of the arch. If I decide to do a surgery in a bone that is not a good guide, that the midline is off, that I have some asymmetry in the arch, and I decide to not do surgery in that guide bone, I will have the same problem at the end of the treatment. So when we decide to do surgery in just one bone, I need to get the other one like a guide. The occlusal plan is very important to see before, the midlines from upper and lower jaw, and to see the 3D teeth, how the teeth are on the bone, and the 3D maxilla or mandible. What about the guide bone? The guide can be maxilla, upper, or mandible. Depends the problem, depends the skeletal deformity of the patient. So look at these CTs and let's see the initial of the case. Here in this patient, the CT, the maxilla is okay clinically, good smile, midline is on, and we don't have a symmetry, transverse is okay. So I will choose the maxilla like my guide bone, and I will do surgery that is asymmetric and a little bit the left side is different from the right side. I will do surgery on the mandible, only the mandible. So the maxilla will be my guide. And I did the surgery just in the mandible and the chin surgery too, to help of the result of the case. So maxilla is okay, I do surgery just in the mandible. And I can have a lot of osteotomies in the bone that I will do the surgery. Doesn't matter. I can do osteotomy, sagittal osteotomy, I can do chin osteotomy, I can change the cant, I can change the midline, I can change the yaw movements, and I correct everything in the bone that I will do the surgery, but the guide will be the maxilla, the other bone. And I have to make sure and to see and to understand that the bone that I decide to not do surgery should be good enough to have and to be the guide of this treatment, okay? It is very important to understand this kind of difference because it is not so common to have the orthogenetic surgery just in one bone. Many of the times, most of the times, I have discrepancies and I have asymmetries in upper and lower jaw. It is very hard to have one bone that is very, very good, in good position, and the other not. But many times I can just, accept that bone that is not so bad, and this bone will be the guide. So look at this view. I just changed the position of the mandible, correcting the position of the midline. I have one side advancing a lot more than the other side. And I have the chin surgery completing the correction of the discrepancy. And everything was done just in the mandible. We don't do any kind of surgery in the maxilla. So here is the patient. He had at the beginning good smile, good projection of the maxilla, and the midline was just dental, midline off. I don't have any kind of asymmetry, bone asymmetry. So the maxilla, I understood that this maxilla was good enough, and I could treat this maxilla with orthodontics, just orthodontics. So I started to measure. I had class 1 in one side and class 3 in the other side. A little bit loose of space at the anterior of the mandible. The midline of lower jaw is a little bit off. And the mandible it is very long in his face. So the patient doesn't have the lips touching. And the patient had a very big high of the anterior part of the face. So we decided to do orthodontics correction in the upper jaw, trying to put the maxilla, the midline on the face, leveling and symmetry of arch was okay. And mandible was totally off. So we decided to have, how we have the midline off, the leveling was not good enough and the symmetry was off. So in this patient, we just we did orthodontics preparation, putting the mandible, the teeth of the mandible in the same position in 3D like the bone position. The final position of the teeth should be compatible with the face deformity. This is the point when we start to prepare a patient for orthogenetic surgery. So that's the point that is very important one. The final position of the teeth should be compatible with the face deformity. Here we have the orthodontics preparation for this patient, and I got one side crossbite, midline off, and maxilla is okay. So I can decompensate it, I can treat, I can prepare this patient in both arches, but I can do surgery just in one arch. It's not a problem. The final position of the teeth should be compatible with the face deformity. That's the point that we have to think. That's one of the points that I think it is very important to have the tomography at the beginning of the treatment, so I can see the difference between the position of the teeth and the bone at the beginning, and in which way I can put the teeth, move the teeth to the right position of the bone, and to correct and to have the same position of teeth and bone. This is very important in a symmetric case. So I got the movements, I had the correction of the midline, I put the chin 2 millimeters to the left side and up a little bit 5 millimeters, correcting the cant and the asymmetry that I got in the chin, reduction, the asymmetry in the mandible, and fill the maxilla with bone cement to get better projection of the maxilla. So here is the surgery. We didn't do any kind of LeFor in this patient. I just put bone cement in the maxilla just to give better projection for this patient in the upper lip and the projection of the face, and orthognathic surgery just in the lower jaw. So this is just mandible sagittal osteotomy and chin surgery and 5-year post-surgery. This is an old case, 2012. We had 5-year follow-up. And we can see here, we have at the beginning, we have the occlusion after orthodontics preparation. I have the occlusion after the surgery, and I have 5 years post-surgery, and showing the stability of the case. In a very, very short surgery, just mandible and chin, it's like 2-3 hours surgery, and the patient had a good stability and good result. So all these steps we have to follow and to see before and to decide before. I need to have all the definitions before the surgery, before the treatment. What about another decision that many times I cannot have just monomaxillary surgery. I need a bimaxillary surgery, where I have to do surgery in 2 bones, maxilla and mandible, because I have many other deformities in that face. So deciding the type of the surgery, looking at the occlusal plane, midline, 3D position of the teeth, and I need to decide. I need the definition. We are going to do both jaw surgery. What about the ortho decompensation of the patient? I have to keep in mind that the final position of the teeth has to be compatible with the maxillomandibular deformity in 3D position. That's the secret of orthodontics pre-surgery. Even if we have just one surgery in 1 bone or 2 bones. So, in sagittal point of view, I need to get the correct overjet, AP inclination of the incisors, and the canines and the molars relation. If the discrepancy of the patient is mostly sagittal discrepancy, I need to have the sagittal discrepancy in the teeth of the patient. So, one more time, it is very important to have the correct diagnosis of the deformity so I can do the correct ortho preparation for that patient. And the definition to have a big or not overjet to decompensate that patient orthodontically depends the diagnosis of that case. If it is sagittal discrepancy, mostly I need to have a big overjet. Or if it is not, I don't need it. If the most important discrepancy of the patient is vertically, I don't need to have big discrepancy overjet in sagittal view. I need to have one more time, the final position of the teeth compatible with the maxillomandibular deformity. In vertical point of view, the vertical position of the teeth. That is the leveling. If I have cant in bone, upper or lower jaw, and if I have any kind of yaw deformity, that is the volume of the face. So I need to see the patient 3D view and try to make the preparation, the ortho preparation, compatible with the craniofacial deformities. When I'm looking at the patient lateral medial point of view, we have to see all the midlines. So the midlines from the maxilla with the face, with the mandible, the chin, the maxilla with the mandible, the maxilla with the nose, and the maxilla with the fold. I have to see all the midlines. Hi, I'm back. Are you there? Thank you for waiting for me. Okay, so just coming back with the meaning about the asymmetric patients. I need to understand all the study that I should do about the midlines. So I need to measure all the midlines from maxilla with the face, mandible with the face, chin with the face, mandible with the chin, maxilla with the mandible, maxilla with the nose, and maxilla with the fold, lip. All the midlines has to be measured before, at the beginning of the treatment. And I need to understand, and I need to see in my diagnosis what is going on with the teeth and with the bone. If I have the midline off and it is only teeth off, or if I have the bone discrepancy. And I need to think and to keep in my mind that I have to put the teeth in the same position of the bone. This is the way that orthodontically I will prepare this patient for orthognathic surgery. This is the most important thing to think in asymmetric patients. So even this, I have to look at the inclination of the molars, because most of the time the asymmetric patients, they have the compensation of the inclination, the vestibular lingual inclination of the molars, exactly because we have the bone off of the position. So this is very important thing, and I need to see this at the beginning. Even if it is supposed to create a very huge malocclusion before the surgery. Look at this patient. I will try to share with you a very good patient to try to understand all these things that we are talking about and try to do a good diagnosis and a good treatment plan for this patient. This is a class 3 patient, an asymmetric patient. He is adult patient, and what I have here to understand that I have a very symmetric mandible in this patient, with the mandible totally different between left and right side, and the chin is totally turned to the left side. I had increased of the height of this face, and I have a very severe malocclusion of this face. So the right side of the face is totally different than the right side. The left side is different than the right side. And what about this occlusion? I have a huge class 3 occlusion, the relation of the canines, and I don't have any kind of space, and the position of the incisors is totally lingual position, compensating the class 3 pattern of this patient. And I don't have any kind of space to align this, because this is the way that the position of the mandible is in this face. And what about the transverse between upper and lower jaw? I have a total cross bite in this patient. And I have to understand how much it means. And of course, this kind of face with this kind of occlusion, malocclusion, I will propose for this patient are orthodontic surgery to correct everything. So this is all the steps that we are going to share, we are going to explain here, because we are going to trace all this planning in this patient, okay? So what is the most important thing in this discrepancy? The asymmetric position of the mandible and the maxilla, and at the same patient, I have a huge mandible, a very prognatism in this patient. I have transverse problems in the upper and lower jaw, and I have sagittal discrepancy too. And vertically, I have the increase of the height of the anterior part of the face. So I will try to see my patient in 3D point of view and try to look at the teeth and how I will prepare this patient for the surgery. So the decisions for the treatment plan for this patient. What type of surgery I will suggest for this patient? Of course, it will be a bimaxillary surgery. I need to do surgery in both jaws, 2 bones, 3 bones, 2 bones, maxilla, mandible, and chin. And which kind of surgery I will suggest for this patient? Why? I have to understand that I have a very high compensating inclination of the lower incisors, and vertically I have a very big growth in this mandible in inferior way of this face. So this is not good for the open bite. I have a huge open bite because of the increase of the height in the face. And look at the transverse discrepancy. I have maxilla and mandible, and look at the molars, the inclination of the molars, the lower molars. I have a lingual inclination of these molars. I have crowded in the incisors, lower incisors, and in the maxilla, I have exactly the opposite. I have the vestibular inclination of the molars and all the teeth of the maxilla, and the bone, I have a very severe discrepancy from the bone. How this patient is gonna to orthodontic surgery, this is very severe discrepancy that this patient has. I need to measure how many millimeters I have the transverse discrepancy to try to do everything, all the corrections in one surgery. I really don't like to do 2 surgeries in my patient. All those patients that needs orthodontic surgery, I don't like to do just maxilla expansion surgery firstly and then orthodontic surgery. I try to do all the corrections in just one surgery. But I have to understand how many millimeters I need to correct in this transverse point of view. And many times, most of the time, I try to use the tomography to help me. So we are going to measure the position of the teeth in the center of the bone. Don't try, orthodontists, don't try to compensate this kind of discrepancy when you are in front of a patient that are going to do orthodontic surgery. Because if you try to compensate the transverse discrepancy, you are going to create an instability in this case. So if the patient is going to orthodontic surgery, we are trying to not compensate the transverse problems, or we are going to do surgery before just to expand this maxilla, just to correct the transverse problem, or we are going to do everything in only one surgery, one orthodontic surgery to correct all the discrepancies of that skeletal anomaly. So, multiple maxillary osteotomies to expand the maxilla with surgery, segmentations of maxilla. In the past, we were a lot worried about this kind of procedure in our field because we thought that many segmentation and many expansion in the maxilla would be very unstable and had a lot of complications during orthodontic surgery. But today we have a lot of instruments that help us, and we have some appliances to make stable the position of the maxilla at the end. So this kind of procedure is very stable if you know how to manage this kind of problem. What do I need to do this surgery? I need the divergence of the roots, like 2.5 or 3 millimeter distance of interdental bone, avoiding the dental expansion mechanics, like transpalatal torques, overexpanded arches. I need to avoid this. Don't worry about the transverse relationship between the arches, because we are going to treat everything with surgery. So I can have, during my orthodontics preparation, the root divergence in segmentation region. Replacing the bracts, I can do this between lateral and canine, that is the teeth that we choose to do this, to do the segmentation. So I need the root divergence and to create a space to segment the arch, the upper arch. Look at this. I have between the teeth, the lateral and the canine, in one side and other side. So this is the preparation that I need to do orthodontically when I plan to do the segmentation of the maxilla. And I have all these instruments to help me, especially the piezo saw that I have to be very carefully and to don't touch the soft tissue and to care about the palate, but it's very safe. So the only instrument that I use today is the piezo saw to create and to do the split, to do the segmentation in the maxilla. I don't use any more saw and burrs, just the piezo. And one more time, I have to think about the final position of the pre-op intra and inter-arch teeth must be compatible with the three-dimensional deformities of the face. So look at this, the maxilla, I can segment the maxilla in 3-piece, 4-piece, whatever I need, and I have to create the space that the patient needs to correct the transverse problems, and to do everything at the same time. So here, in the sagittal point of view, I don't need so many discrepancies because I already has at the beginning the discrepancy in this view. The AP inclination, I have to put in the best position the teeth in his bone, in vertical and asymmetry. So all the axes, I have to do the decompensated orthodontically. And here, look at the CT of this patient prepared for orthognathic surgery. I have the discrepancy in the teeth, and I can measure the difference between one side to another side. So the right side and the left side are totally different because of the bone asymmetry that this patient has in the maxilla and the mandible. And this is the orthodontics good preparation. I have the chin of 4.5 millimeters, and I have a discrepancy in the cant, in the mandible, of 4.5 millimeters too. So all these measurements, we can calculate it from all the planning that I'm suggesting for this patient. I need to understand that the midline of lower jaw should be the coincidence to mandible, midline, plus cant. Because I have two kinds of discrepancy in this mandible. I have the midline of lateral medially, and I have vertical discrepancy. So I have a plus. It is not totally in the lateral medial point of view. And I need to understand this to can plan correctly my case. So here is our patient. If you see this patient after the orthodontics pre-surgery time, you can understand what happened with this patient. This patient, when we started to prepare this patient orthodontically, you can see that the soft tissue is a lot relaxed, and the patient is more skeletal discrepancy. It is more clear when you are ready to do surgery. So in this way, we are going to see all the compensation orthodontically that you did firstly in this patient. And you have all the discrepancies showing the problem, the pathology of this patient. In this point of view, you are going to prepare, you are going to keep all this discrepancy to do your plan. And now we have the last step before the surgery. We are going to do, at this point, we are going to do another facial analysis with photos and with clinical evaluation. We need a new tomography for the patient to do the virtual planing, to do the surgery, and to do the splints for the surgery. We need to do a virtual planing very precisely to have predictability in the result of the planning. We need new casts, and these digital casts, I always ask for print, and I took in my hands to put in the final occlusion of the patient. And after all this workflow, we are going to end the planning, the orthognatics planning with the splint. So, since the first appointment until this time, we have all the steps that we need to follow, and we have all the thoughts that we need to understand to do the best preparation for the time of the surgery. When you are in the final of the preparation, orthodontics preparation, you are going to start another protocol, another sequence of steps to prepare your patient to the time of the surgery with all this workflow. And in this way, you are going to get the best orthognathic surgery that the patient needs. So here you can see the preparation and the surgical planning for this patient. So we planned for this case a 3-piece maxilla because I needed to expand the maxilla, and I'm not afraid to expand like 8, 9, 10 millimeters maxilla transversally and correct the transverse atrophic maxillas, because it is very safe if you are having a good technique and a good surgery. We did a sagittal split, a sagittal osteotomy, both sides of the mandible, and a chin surgery. So it is a surgery that we have to decrease the height of the face, correct the asymmetry of the patient, try to put the maxilla forward, try to put the mandible in the right position laterally, decrease the height of the chin, and all of the movements at the same patient. This is a very complex case in orthogenetic surgery, and we do all this planning very predictability because we doing all this digital and virtual planning that help a lot to have secure to do this safely. So here is our final result of our patient. We have first CT in the end of the surgery. Many times I can see a little bit of some difference between the sides, but clinically it is very hard to see something. The patient became very normally. This is the final occlusion after the surgery and the change of the face of this patient. So we have the bone plates in the right position and good position of the plates, just 2 plates in both sides in the maxilla. And I just put 1 plate at the anterior part of the maxilla and 2 plates both sides in the mandible, and the chin, 1 plate and 1 screw. And here is 3 years follow-up of this patient. The pre and post and the stability. Many times I have some kind of small discrepancy of the patient on the back because of the tongue and some function of this patient. But a very good case, the final result. So, concluding, to end our lecture, I would like just to tell you that you need to keep in mind all these steps. So first step of my protocol is to have a very good documentation of the patient at the beginning, so you can define the problem that you are in front of. The second step is to have and to get the correct diagnosis of reading correctly the face of the patient. And for this, you need a face reading protocol. So you're going to measure all the movements, everything, all the numbers of that face. The first step is the definitions of the treatment. What type of surgery I will try to suggest for this case, which kind of extraction I will suggest, all these definitions, if the treatment will be in one bone, 2 bones, which kind of surgery this patient needs, about the airway and other pathologies that the patient has. Fourth step, I have the definitions of ortho preparation. That is very, very important to have success in your treatment. And the last step is the orthogenetic workflow, definition of the surgery, all the movements that you are going to do in your patient to have the best result for your case. Okay? So all these steps you need to follow, And this is the biggest important thing that you have to understand, how to treat and to follow this protocol. That's it. I would like to ask for some question. If you have any kind of question, if you would like to ask me, I'm here just to answer. I would like to thank you to be here with me this afternoon, this evening. And it was very nice to have this time here with you. I would like to thank you one more time. Hi, Alon. Thank you so much for your question. And in just a second, I will answer, okay? And you, if you have any doubt, you can put here your question. I'm here to answer any doubt that you have about this topic. And I would like to invite you. Officially, it's open our mentoring. That is Planning with Excellence, that we are going to start all the mentoring one by one, and it is officially open. And this mentoring is for all the orthodontists or surgeons that would like to improve the treatment for craniofacial deformities. If you have a very complex case in your clinic, and you'd like any suggestion, and you'd like to see all the suggestions that I can give to you to treat a very complex case, this is the best point, the best way to have the mentoring. And you are going to send to me some records from your patient, x-rays, tomographies. I will study the case, and I will plan for you and with you about that patient. So I will suggest in a record, and I will suggest what you should do for that patient, orthodontically and surgically. And it is going to be easier for you to treat and to have good results in your cases. So don't waste, don't miss the mentoring. And the registration is officially open right now. In a couple minutes, we are going to talk a little bit more about this mentoring that is officially open. Elon, I'm just reading the question. When planning asymmetric patients with significant difference in values of high of the Ramos, on the basis of which signs you decide which side is healthy or which requires correction? Very good question, Ellen. We try to see everything about the Ramos, so we are going to see the TMJ from both sides. And I will try to see MRIs, CT scan, the shape of the condyles, the morphology of the condyle, and I will try to see this patient from the growth, because many times you have a patient, many times I have the decrease of the growth in one side, or I have hyperplasia condylar in another side. So if I follow this patient for 1 year, I can compare and I can see what happened with that condyles. And I can treat correctly the pathology side. So I will compare the shape, the morphology, and I will compare in a couple months what happened with that condyles. If I have hyperplasia condyle, I have some characteristics that I need to understand. The length of the condyle, the size of the condyle, the symptoms of the patient. So we have many things that I need to use like criteria to decide to do surgery in one side or another side, okay? How do you technically perform Ramos symmetrician directly in the operating room. Many times, normally, I perform before. What I do is I print the 3D model that I did the virtual planing, and I did all my planing, surgical planing, and I print this 3D model, and I do this before the surgery, and I have a cut guide, and I do this cut guide, and I take this cut guide to the operating room, so I can correct exactly the size of the ramus, the difference between one side to another side. I don't do this just looking with my eyes. I do a 3D model, I cut with a guide, and I take this guide, this cut guide, to the operating room. Okay, Ellen? How do you determine the age limit for surgery in patients with 3 skeletal class 3? What factors should be taken into account when deciding on the time? You know, many times I just follow my patient to see if the patient is still growing or not. So if I have a class 3 patient and he is 14, 15 years old, that is not the biggest, the most important point. I like to follow the patient and see the speed of the growing of the patient, to compare the CTs from one year to another year. And if I do the diagnosis of condylar hyperplasia, I don't wait many times to the adult age. I can do surgery before, during the same orthognathic surgery, I do the TMJ surgery, and I do the condylectomy, the high condylectomy, so I can have predictability in my result. Priscila Gonçalves, thank you for your question. If I use the same protocol of fixation in the cases, I changed it, Priscilla. This case that I just showed you is a 10 years old case, and today I use just an L plate in the mandible and 2 screws on the back, bicortical screws on the back, and an L plate on the front, on the sagittal osteotomy. I don't use anymore 2 straight plates on the mandible. Okay? Anna, thank you. Do you or your orthodontist use a splint before surgery to stabilize the joint? Sometimes it is necessary if I have a patient that are very symptomatic patient at the beginning of the treatment. First of all, I think it is very bad to start something with a patient with pain. So we use splints, yes, to make this better for the patient, to control the pain of this patient. And after this, we started the treatment. But we have to understand the diagnosis and what is going on with the TMJ before everything, and try to keep this TMJ in the control. Otherwise, we are going to have problems after the orthognathic surgery. Sergio, thank you. Please speak about the TMJ position at transoperatory moment. Hi Sergio, thank you for your question. This is something that is very hard to speak, but we have exactly a protocol way during the surgery to put the TMJ in the right position. So it is another lecture that we use a special instrument, and we put the position of the median border of the mandible, and the TMJ, we have exactly a technique to put the TMJ in the right position. It's not so easy to talk and to explain, but I can do a lecture just about the technique, surgical techniques, okay? Roxana, thank you. I have a surgical case, class 3. How can I register for mentoring? Oh, we are going to just give you the link below, and you can come here and click on the link and guarantee your spot in the mentoring. It's very interesting, and I can help you. I can help you to plan your class 3 patient, for sure. We are starting a new phase of projects, and I want to be with you. The subscription for planning with excellent mentoring are officially open. So if you are interested to have a mentoring with me, that's the time to have your registration right now. Don't waste time. Don't lose this opportunity to do your registration. Officially open today for my mentoring. This is one by one. We are going to meet and to have an appointment, and I will suggest a lot of things that you should do during the treatment from your patients. It will be easier for you to treat and to have good results. For launch occasion, the first 24 hours, we have a super special condition for you. So don't miss time, don't waste time, and just do your registration right now. We are going to have a mentoring very special condition, 30% off, but just today we have this bonus, okay? What is the this is a question. What is the worst side effect after surgery, and how do you avoid this? This is a question for turn. The worst side effect after surgery, I think it is bad consolidation of the bone. If the patient has any kind of parafunction habits and chewing, and we are going to have a lot of bad consolidation of the bone. Prestige, I don't think that is, you cannot avoid the hyposensitive in your lips or tongue or all the face after any kind of surgery, because it is something that we need to care after the surgery. Take care with the technique, take care with all the steps during the surgery, but it's not something that you can avoid totally, because it is inherent from any surgery, okay? Hi, Justina, thank you so much. Thank you for everybody that is just happy with the lecture that I gave. Another question, Sergio, the importance of a good position of the TMJ at the transoperatory. Thank you. Oh, it is something that is one of the most important things during the orthodontic surgery, is the position of the TMJ. I need to have the stability of this TMJ, to have good stability in my occlusion. So the position that you put during the surgery is the most important thing to get the occlusion that you planned. It doesn't matter if you had planned the wonderful planning, surgical planning, and if you don't have the TMJ in the right position during the surgery, you are not going to have the occlusion that you planned. So it is, you know. Okay. Mantas, thank you. I'm glad that you like the lecture. And reminding you, from now, it's officially open, my mentoring of planning with excellence. If you are interested to learn more with me, don't lose time, don't lose this opportunity to do your registration right now for my mentoring. The mentoring is gonna be appointment one by one that I'm going to suggest for you a lot of things, how to treat in the best way that I think is the best way to treat your patient, your skeletal deformity patients. Okay, one more question. Dr. Vanessa is asking about the orientation of the head and how I can transfer to the 3D planning. You know, Isabel, I use a lot of points that I transfer, but what I do the facial analysis with the patient in front of me, and I have the computer besides me. So I'm trying to put the head of the patient in the right position, and I will do all the measurements in the face of the patient, and at the same moment, I'm correcting the tomography, and I try to put the same thing that I'm looking at the face, I'm looking at the CT scan. And in this way, I can see some asymmetry in the eyes, in the ears, and I can correct this clinically, and I transfer to tomography this. I don't use laser point anymore because I don't need it, but you can use, and I think it helps. But I'm not, you know, it is not the most important thing. What I think it is mostly important is what you see in your patient clinically in front of you, you transfer to CT scan at the same moment. Every patient I do facial analysis at least 2 or 3 times. So firstly I do one check, and after 1 or 2 days, double check, and then third check. In this way, I can have the positions in the CT to start my planning, my virtual planning. That's the way that I do, okay? Okay, Dr. André, thank you so much. Thank you, Isabel. Welcome. Any doubts? I'm here to answer. If you want, you can just leave on the chat the doubts, and I will try to answer later for you. I can just write and answer the questions that you have, okay? Thank you, Lorenzo, Angelo. Thank you so much. And one more time, don't miss the mentoring that is officially open. We just opened the mentoring. The registration is officially open. You can just make your registration right now, put in your name and click the link below, and it is gonna be a pleasure to help you and to suggest for you how I think it is the best way to treat your craniofacial deformities patient, and how are gonna be my suggestions for your case. I can help you to treat and to get best results. It was a pleasure, a great pleasure to be here today and to share with you a little bit of my experience from all these years working with this and working with these skeletal patients and doing orthodontic surgery almost every day. Bye-bye.